Here's the next lesson in our trauma unit. It's lesson 8 on chest and abdominal injuries. This is a key lesson. These can be life-threatening injuries, whereas soft tissue and musculoskeletal injuries can sometimes be of life threat. Chest and abdominal injuries are frequently a big deal. So we'll spend 2 hours online having you work through some material here, and then an hour in the face-to-face lab. The lab for this is mostly about sealing up open chest wounds, finding all of them and sealing them up. And we integrate that on with total trauma patient care. So content here, we want to talk about the anatomy of the chest and the abdomen a little bit. I'm going to focus a lot on chest in terms of understanding what the pleura do and pneumothorax management and assessment. Then we're going to work on open chest injuries and then talk about abdominal injuries a little bit. So right off the bat, important thing to understand, anatomy in the chest, particularly about the pleura. This concept of the pleura will, if you have this down, will help you understand a pneumothorax. So there are two pleura, the visceral pleura and the parietal pleura. The parietal is easy to understand. It's the inside lining of the chest wall. If you were to poke a hole in the chest and stick your finger in and feel around the inside of the chest wall, you would feel a smooth lining there, and that is the parietal pleura. The visceral pleura lines the outside of the lungs. And those two pleura are stuck together. The pleural cavity or pleural space is a potential space. There's not supposed to be any space there. There's some fluid in between the two pleura, and that fluid keeps those two pleura stuck together. So that as your chest expands, because the pleura are stuck together, the pleura around the lung is stuck to the chest wall, and as your chest expands, then it kind of drags the lungs with it, opens up, and as you take a breath, you're generating a little bit of negative pressure inside your chest, and that allows air to rush into your lungs as long as the lungs are expanded, and they're expanded because the visceral pleura is stuck to the parietal pleura, which is stuck to the chest wall, and as you increase your chest size, as you take in a deep breath, then you're able to pull the lungs open and air is able to come in. The pleura need to be stuck together. When they are disrupted because of a hole or a rib that broke and poked a hole or something, then you end up with actual space in that pleural cavity, in that pleural space, and that's where the lung can collapse. We can talk about a pneumothorax here in a little bit. Also notice the primary muscle of respiration and primary muscle of breathing is your diaphragm. It's a dome-shaped muscle, and as you take a deep breath, you actually contract that diaphragm and flatten it out and create a little bit of space and help create that negative pressure. Also, we've talked about, or we'll talk some more about, the pulmonary system, the respiratory anatomy being like an upside-down tree. So you have the trachea as the main trunk of the tree, and then the two main divisions there, the left and the right main stem bronchi. Each of them is called a bronchus. So you have a right main stem bronchus and a left main stem bronchus. So together they're called the main stem bronchi, and that is the first division off of the trachea. The main stem bronchi divide further and further and further into more and more bronchioles, and eventually at the very end of the system, the upside down tree, you have the twigs of the tree coming off the smallest of the limbs. So those twigs would be the bronchioles, and then the alveoli, of course, the tiny air sacs, the microscopic air sacs, we have a bajillion of them, and those are the leaves on that pulmonary tree. Your ribs, part of your musculoskeletal system, are to provide structure and stability and allow that chest to be intact and expand, and then your sternum, breastbone, right in the center, and then, of course, your lungs. So general basic anatomy with a lot of emphasis on pleura. So there can be lots of different types of chest injuries. You can have a simple rib fracture, just one. You can have multiple rib fractures that are next to each other and broken in a couple of places. You can have a flail chest from that. A pulmonary contusion would be bruising to the lung. You can have a simple pneumothorax, a tension pneumothorax. You can have a hemothorax. You can have a hemopneumothorax. And then we need to talk about open or sucking chest wounds. So we'll go through each of those one at a time. Rib fractures hurt a lot. So patients will breathe very shallow because it's so painful. So their rate will be up a little bit. Their effort will probably be up, and their depth will be down. They will be breathing more shallowly than normal. The other thing about rib fractures is that a broken rib can poke a hole in the lung. It can disrupt that pleural integrity to where you now have a collapsed lung. And then also, if it took there was enough force to break the rib, then there must be some bruising to that underlying lung. So rib fractures are a big deal. Sometimes a simple rib fracture is just painful, heals on its own over time, and doesn't lead to anything worse. Sometimes a simple rib fracture can end up in a pneumothorax or worse. There's a specific type of fracture called a flail chest. And this is where you have 2, 3, 4 adjacent consecutive ribs. So not one on one side and one on the other side, but these have to be right next to each other. And they're broken in a couple of places, so you end up with a segment of chest wall between the breaks that is not supported. It's not connected to the rest of the rib cage. So when you take in a breath and you create a little bit of negative pressure, usually when you take in a breath, your chest wall is expanding, but this unsupported segment will then suck in the direction of the pressure. And then the opposite occurs on expiration. As your chest relaxes and returns to normal, there's positive pressure inside your chest as you exhale, and that positive pressure will cause that unsupported flail chest segment to flail out. So the flail segment will move in the opposite direction of the rest of the chest, called paradoxical chest wall motion. Initially, that may be hard for you to see when the injury just occurred. The intercostal muscles, the muscles between the ribs, will be contracted and spasmed enough that they will be stabilizing that flail, and it may not be all that visible in the field or right after the injury occurs. But over time, those intercostal muscles become fatigued and are no longer able to provide any support, any splinting, and the paradoxical chest wall motion, that flail segment, will become more obvious. Remember, if there was enough force to break one rib, there was certainly bruising underneath. And in this case, you've got several broken ribs, so we're pretty sure there is some contusion, some bruising to that lung. And if one rib fracture can poke a hole, now you've got 2, 3, 4, 6 fractures involved here. So it's pretty likely that you'll have a punctured lung and a developing pneumothorax underneath. In the old days, we were taught to use a large bulky dressing, something heavy, a small sandbag, or something the size of an IV fluid bag, and was thought to be of some assistance. That's been out for several years. So this bulky dressing or a heavy dressing, heavy bandaging, splinting of this flail is really out. It's pretty much worthless. It always was worthless, but we finally admitted it a few years ago. And so now the thought is that really the problem here is that you have this negative pressure breathing that's causing that flail segment to flail in. If we just take over and do positive pressure breathing, now the chest wall is going to be moving in the direction of the pressure instead of opposite with normal breathing. And so positive pressure breathing will splint that flail. So that's great if all we're worried about was the flail. But we already said that it's almost certain that with that many rib fractures that you've got a hole in a lung. So now you have a simple pneumothorax. You have a hole in a lung, a partially collapsed lung. And now the pleural space is no longer just a potential space. There's actually air in there. And so positive pressure will convert that simple pneumo into a deadly tension pneumo much more quickly than if you weren't using positive pressure breathing. So this leaves us in kind of a no man's land, kind of a catch-22. There's not a good answer for what we should do particularly at the EMT level with flail chests. Obviously, ventilation is going to be a problem. Oxygenation is going to be a problem if part of the lung is out of service. But if we take over with positive pressure breathing, then we're more likely to take what was a simple pneumothorax that doesn't kill and turn it into a deadly tension pneumothorax. So different protocols will say different things. We're going to stick with positive pressure is the best way to splint the flail, but there are overwhelmingly dangerous side effects to that. And so only in the most extreme or special case would we do that. The problem with a tension pneumo at the EMT level is that EMTs aren't able to relieve that tension in most cases. And so you create something that you can't fix that is deadly in an effort to try to correct something that was probably not going to be deadly. So we'll work on this in lab. We'll talk about it some more. You should spend some time thinking about this, read about this in your textbook, and make sure you understand both the definition of a flail and why the treatment for it can be worse than the underlying problem. Pulmonary contusion is just what it sounds like. It's a bruise to the lung. The alveoli should be full of air, but now they're full of blood. And so the alveoli are not able to do their normal job. There's no air that can deliver oxygen to the blood and take away carbon dioxide. And so your normal gas exchange is messed up because there's blood where it shouldn't be. When you listen with a stethoscope, that's called auscultation. So when you auscultate over an area of bruised lung, you're going to hear very little, if any, air movement. And so when you're auscultating a chest and you hear little or no air movement, it could be that the lung underneath of there is collapsed. There's a pneumothorax that you're listening to, and so there's no air movement inside the lung, so you don't hear anything. Or it could be that that lung is full of blood, and there's no air movement inside the lung, so you don't hear anything. So a stethoscope is really not a definitive way to determine whether you have a pneumothorax or you have a pulmonary contusion. Both of them are bad. The contusion usually takes a little while to develop, so if you arrive right after the traumatic injury to the chest occurred, for a contusion to develop that quickly is really uncommon. So if you have a short response time following immediate alert for a car crash or something, and you find a patient who has diminished lung sounds, it's so far much more likely that that is a pneumothorax, that's a collapsed lung, than it is that it's a pulmonary contusion, a lung full of blood. Over time, of course, the contusion is going to grow. It's a bruise. There's leaking blood into that area. And so as time goes on, it becomes less simple to decide whether that diminished lung sound is from a pneumo or it's from a pulmonary contusion. Now, a pneumothorax is air in the pleural space, air in that pleural cavity from the previous diagram. Air outside the lung, but trapped inside the chest. If there's blood outside the lung, trapped inside the chest, it's called a hemothorax. So we wanted to mention hemothorax on the same slide as pulmonary contusion and make sure that we understand that those are different things. Pulmonary contusion is blood inside the lung, and that's usually not going to be a massive amount of blood loss. Hemothorax is blood outside the lung trapped in the chest cavity in the pleural space, and that can be a massive hemorrhage. That can be a life-ending hemorrhage. So some of the stuff on your assignment and some of the questions we'll ask you down the road, to get you to understand and demonstrate your understanding of the definitions of pulmonary contusion and hemothorax and differentiate the two. Simple pneumothorax, the lung is collapsed. There is air in the pleural space where there should be nothing in the pleural space. You can have what's called a spontaneous pneumothorax. That can come from just a congenital weakness in your lung. And for some reason, tall, thin, young males are more at risk for this than other folks. Don't understand why. It just is what it is. Seen it. It's a real thing. And so you can just spontaneously pop a hole in a lung for no good reason and come up a little short of breath, maybe a little nauseated. And on x-ray, for sure, you can see that there's a partially collapsed lung. And on auscultation, you may be able to appreciate that that's the case. Another type of spontaneous pneumo is particularly in those with lung disease. So there's some damage to the lung tissue to start with. Maybe a coughing spell or something initiates it, and they end up just popping a hole in the lung. And those are spontaneous pneumothorax. More than one pneumothorax is called a pneumothoraces. So spontaneous pneumothoraces can occur either from congenital weakness, typically tall, thin young males, or in someone with lung disease, typically after a coughing spell. So lung sounds are hard to hear. Use of a stethoscope, even a really good one in the field setting, is not all that straightforward. It's easy for us to show you where to listen. It's easy for you to learn how to listen. It's just hard to hear. Then when you put that in a more high noise environment like we typically work in, and really we need to understand that lung sound assessment by auscultation is really kind of vague, and it is not necessarily going to give you the specific answer that you're looking for. When you add to that the fact that in many cases in the field setting, you have really low quality, cheap stethoscopes, that makes it even harder. Now, stethoscopes are something to talk about briefly here. You get what you pay for in most cases. When you come to the paramedic program, we tell you in one of the first days, you should get a good stethoscope. And you should get the good one you're going to have for your life now, early on, so that you get used to listening to lung sounds with a good stethoscope. Don't go through a year of the $3.95 disposable stethoscopes and then suddenly get a good one, and all of a sudden you're hearing things that weren't there before. So on the fire district, we have decent stethoscopes in our EMS packs. They are adequate for lung sound auscultation. They are adequate for blood pressure determination. But in a lot of cases, you'll end up with these really, really cheap things that you just can't hear anything through anyway. So lung sounds are how you decide what's going on in the chest in most cases. You do that with auscultation with a stethoscope, but there's problems with that. It's hard to do, it's hard to hear, and you got to have a really good scope to be fairly sure. Then the last thing on simple pneumothoraces is what I mentioned earlier with the flail. Positive pressure makes it worse. So think about as the patient takes a breath, air comes into the lung. As they exhale, air goes out the patient's mouth and a little bit goes out the lung, the hole in the lung, and is trapped in the chest wall. A little bit with each breath. So over time, that builds up. Now, that's with negative pressure breathing. That's normal breathing for a person. What if we switch to positive pressure breathing? Now, as we ventilate the patient and blow some air in, it goes into the lung, a little bit goes out the hole. Then as they exhale, a little bit more goes out the hole. And so we can more rapidly turn a simple pneumothorax into the more worse, deadly, scary version called a tension pneumothorax. A tension pneumo is a simple pneumo that has progressed. Sometimes it progresses very rapidly over the course of a couple of minutes. Other times it takes a little bit longer. The tension pneumo is both a pulmonary problem and a circulatory problem, and it's the circulatory problem that kills. Yes, the lung is collapsed, so we're having trouble with oxygenation because we don't have as much lung tissue in service as we did before. But the collapsed lung is just one thing. It's the buildup of the pressure outside the lung, inside the chest wall, in the pleural space, that's the major problem. As that pressure builds up, then pressure is exerted on the heart, on the vena cava, so the inferior and superior vena cava, particularly the inferior, is easily compressed. And that building up of the pressure, squeezing on the return pipe to the heart, reduces preload, which is the amount of blood coming back to the heart. The heart can only pump out what it gets in. So if it's got reduced blood coming back, then it's going to have reduced blood going out. So cardiac output's going to drop. And if you remember the elements of blood pressure, we have heart rate, stroke volume, which drops when preload drops. So stroke volume drops during a tension pneumo. And we have systemic vascular resistance, how vasoconstricted they are peripherally, how clamped down the pipes are. So patients with tension pneumothorax will have an elevated heart rate and clamp down peripheral vessels in an attempt to compensate for that third piece of blood pressure, the reduced stroke volume. So how do you get a tension pneumo? Well, you don't have to have an open wound. You can have a simple rib fracture that pokes a hole in a lung, and over time that simple pneumo develops into a deadly tension pneumo. But certainly if you have an open chest wound, you would want to have sealed that up so that air goes in through their mouth like we were designed, not through a hole in their chest. But by sealing up that wound, which is the right thing, but by sealing up that wound, now we aren't allowing that tension that has built up in the pleural space to be released. So if you notice that there is a tension pneumo in place on your patient and you have sealed up an open wound, release the seal. Open it up enough to try to burp the air out of that chest. Perhaps that will work. Sometimes it will, sometimes it won't. That's not a nice clean hole made by a bullet or a knife or whatever else poked a hole in their chest. It's probably not a nice clean hole. There's probably some dirt in there. There's probably some shirt in there. There's probably blood clots and tissue chunks. It's not a nice, clean, open, patent hole. And so, yes, you should release the seal, and let's hope that that works, but it may not. Traditionally, over the years, in assessment, you were taught, or, well, other people were taught, you aren't going to be taught this because you're getting it straight and right from the start. But in the deep, dark past, we were taught that tracheal deviation is what we need to look for in order to notice that there's a tension pneumothorax. This means when you feel in the sternal notch, right below the Adam's apple, when you stick your finger in there and feel the trachea should be midline. It should not be deviated off to one side or the other. Tracheal deviation is a very late sign of tension pneumo. May not even be able to accurately feel it in the field, particularly in some of our fluffy patients. And so tracheal deviation, yes, we have to talk about it. And yes, you should think about it when you're doing a rapid assessment of the neck. But this is not something that you wait on to say, oh yeah, my patient's got a tension because now his trachea is finally deviated. The next term is JVD, jugular venous distension. The jugular veins, external jugular veins and internal, but particularly internal is the ones we're talking about here, visible in the neck when there's a lot of pressure inside the chest. So pressure inside the chest from a tension pneumo will cause JVD, as long as there's enough blood left to still fill up the system. But jugular veins that aren't full can't distend, can't be swollen and obvious. So JVD is great. JVD can, it's great to find. It's not great to have, but it's great to find, and it's great to know about. It's much more valid of a predictor than tracheal deviation. But remember that if your patient has bled out in their belly or in their chest or on the street, there may not even be enough blood there to distend those jugular veins. So really what we're down to is the two signs of a tension pneumo, and this is a key point, so you should, remember this, write it on your arm, don't take a bath until you've learned it, something like that. You should know that it's hypotension and one-sided loss of lung sounds. If your patient has an open wound on the right side of their chest and it's been sealed up, and during your reassessment you find that they no longer have a radial pulse on either side, or you've measured their blood pressure and found it to be below 90 in the 80s or 70s, so you have hypotension, whether estimated by radial pulses or measured with a blood pressure cuff, and one-sided loss of lung sounds. That's a tension pneumo. It's not or, it's and it's hypotension and one-sided loss of lung sounds. Now, the possibility here is that this is not a tension pneumo. It's a hemo. They bled out into their chest wall, or they have a large pulmonary contusion that's causing you to have loss of lung sounds on that one side and a big bleed somewhere else. But this is what we're working with in the field setting. It's not that we don't know what to do. It's that we don't have advanced diagnostic tools to where we could see. If we had a chest x-ray or a CT scan that we could see in the field, well, we would get this right every time. But with limited information, incomplete information, we have to make judgment calls. And so management of a tension pneumo is based on the presence of hypotension and a unilateral one-sided loss of lung sounds. I've mentioned hemo 2 or 3 times. Realize that you can lose your entire blood volume into your chest cavity. You don't have to bleed one drop on the street. You can bleed out entirely internally. And so pneumothorax can be massive internal blood loss in the chest. When you listen over the area of the hemo, you're going to hear diminished or absent lung sounds. The lung is collapsed, and there's blood in the pleural space. And this is a huge problem that will definitely lead to hypovolemic shock and the term exsanguination. This is exsanguinating hemorrhage. The term exsanguination meaning bleeds out. So a couple of terms there, a couple of things to think about, and then back to open chest wounds. Big important thing. You've got to find all the open chest wounds, not just the one on the front. So if we give you a call of a drive-by shooting and the shooters have driven by and are gone, it's relatively safe enough to enter, at least for now. You go in and you find a guy with an obvious gunshot wound in the front of his chest. You should seal it up immediately with a gloved hand, and then replace that glove as soon as you can with a real occlusive seal. Something that air doesn't go through. It's occlusive. We have commercial chest seals available in many cases. Those are great. If not, any kind of plastic wrapper, maybe the plastic bag from the oxygen mask, maybe an AED pad, a defibrillator pad, but seal it up with something real as soon as you can so you can get your hand freed up and move on. But then you've got to roll them quickly and look for other wounds. And once you seal up an open wound, you have to be very vigilant for the development of a tension pneumo. Open abdominal wounds can be a big blood loss concern, both internally and externally. Obviously a huge infection risk. And a large open abdominal wound can let a significant amount of heat loss out because the core of the body then is exposed to the environment. And then that particularly gross picture shows you an abdominal evisceration. An evisceration is when things that are supposed to be inside the body have protruded outside the body. In this case, it's a loop of bowel sticking out from a knife wound. These are exceedingly rare to see. They're in all the EMT books, and you would want to manage that by maintaining temperature control as best you can. So something moist, a moist dressing, moist covering, and then as much as you can, keep the heat in. In the past, we carried saran wrap and aluminum foil on the ambulance. The saran wrap was to cover this wound and with some moist gauze underneath of it, and then the aluminum foil was to go over the top of it. Now, it wasn't like we saw a bunch of abdominal eviscerations. We were always ready for cleanout from the barbecue at the station, but they were there really to manage these eviscerations. And so we want you to know that term. Blunt abdominal injury, there can be a large amount of blood loss that is not visible. Now in this picture you can see some ecchymosis. You can see some evidence of blood under the skin there or internally. That doesn't show up all that often. You would have to have the right lighting conditions and the right skin color of your patient. But this is uncontrolled blood loss. And a little bit of blood in the belly, a little bit of free blood in the belly will really, really make the abdominal muscles angry. And they will tighten up in order to protect. And then as time goes on, you may even be able to notice some swelling, some abdominal distension. Recently saw a gunshot patient who we were called right away. We had a short response time, rapid scene time, and during transport, so say 10 to 15 minutes after the injury occurred, he had such a large bleed in his belly that his belly was starting to distend, and he's a very skinny young male who looked like he was 3 months pregnant. So you will sometimes be able to appreciate abdominal distension, not always, and something for you to check on and think about and just remain vigilant for. So in summary here, find all the open chest wounds and seal them up, not just the ones in the front, also the ones in the back and on the side. It is important to strip your patient, and then it's important to cover them back up to maintain warmth. So we've got to see them in order to find all these things. Constantly reassess for a tension pneumo when you have the presence of a simple pneumo. Simple pneumos can turn into tensions in a big hurry. And then there's a list of terms for you to know: the simple pneumo, the spontaneous pneumo, the tension pneumo, a hemothorax. Again, if you have air and blood in the chest wall outside the lung, that's a pneumothorax. Then you have pulmonary contusion, which I spelled wrong. Sorry about that. Then you have flail chest and abdominal evisceration, and I did spell evisceration right. So a list of terms for you to know. Chest abdominal trauma, big important lesson, because these things kill patients. And we'll work in this on lab. We'll work on these patients to where you'll be able to rapidly assess them, find all those wounds, seal them up, keep reassessing, find that tension, pop the seal loose, and understand what's going on with all this stuff. So we'll see you in lab.